Okay, today Sharon is going to introduce our presenter because she's the one that made the arrangements for this and all that. And I'm going to hand it over to Sharon, who is one of our club members.
This is
Good morning,
Sharon.
everyone. Thank you so much for coming. I first met Dr. Donovan in June or July of 2020 when my husband was diagnosed with valley fever. And now I'm obsessed with making sure people are aware of what it's all about. So without further ado, it is my pleasure to introduce the incredible Dr. Fariba Donovan. Dr. Donovan.
Thank you so much. You can hear me well, okay? And when I move my head, you still can hear me, right? Okay, now you're good. Well, thank you so much for the invitation. I'm really pleased to be here. Thank you, Sharon and Les, for having me here. This is a great venue, and I'm really impressed all these people are here. When we have a lecture in the university, we are happy if 2 people showed up. So, thank you. As Sharon said, we go back now almost 2 years. Sorry that her husband unfortunately didn't make it, but that's one reason we are here, to raise awareness, to hopefully prevent that from happening to everybody else. So please feel free to interrupt me anytime you want. This is very casual, and I try to be as thorough as I can. Sometimes we like medical terminology, so stop me if something doesn't make any sense. Okay, so today, actually, part of this talk is exactly the same thing I had last time for people about a year ago in Rotary Club, but part of it is different. So I apologize if it's some part of it is repetition of last year. Let's see. Is this going forward? Okay. Does this work? Or could do it
Just a minute. Do something. I'm going to have to do something here. I know it was, and I was so proud
So
of
while we are
myself.
getting this technical issue resolved, I have some flyers here for you that shows where we are, what we do. We have a website at the back of this flyer, Valley Fever Center for Excellence. So please log on. We have several educational videos. Perfect, thank you. What did you do?
I fixed it. Yeah, I think this will work now.
Yes.
Okay.
Perfect. Thank you. Hold it this way. So I have no conflict of interest to disclose. So the objectives that I will be talking about today, one is what is the clinical presentation of valley fever, and how do we manage the disease, and how do we diagnose it. The next thing is how we can improve the diagnosis, so we diagnose this earlier, so we prevent complications that I will talk about. And the last thing is biologic response modifiers. Maybe you know somebody, maybe you are on some of these medications nowadays. It's quite often that people go on these medications. They decrease your immune system, so you are at risk of this disease. At the very end of my talk, I will talk about this, which is what I'm working on right now. So what is valley fever? Somebody asked me, can you read that name? It's coccidioidomycosis, fancy name for valley fever. It comes from a soil fungus Coccidioides immitis and Posodacea. The difference between these two is only geographic difference. So immitis is mainly
You're not gonna find
in
this.
California. And Posodacea is in the rest of the endemic area for this fungus. I'll show you the map, but it's pretty much Arizona, northern part of Mexico, western part of Texas, Nevada, and now parts of actually Washington state have been reported to have this fungus. So most of those are Posodacea. Oops, sorry. I'm trying to learn this, sorry about that. So coccidioidomycosis is another name. We love to abbreviate and make it fancy. So cocci is another name we call this. And I'll tell you why we call it cocci. The infection usually about 150,000 new cases a year, but actually this is much more than this. This is what reported recently. CDC has changed this, but technically 1/4 can cause the disease. So remember that in the right circumstances. Spectrum of the disease, it means you really don't know you have it. Thank God for that, right? But then 30% are people who may have a pulmonary infection like pneumonia. And what that resembles nowadays? COVID, right? So everybody has COVID until we prove it otherwise. People miss this right and left all the time for that exact reason, or the past 2 years. Before that, they would say, oh, you have a bacterial pneumonia. So remember that 30% are those people with upper respiratory tract symptoms. And then about 10% are people who are really sick. Those are people that we see in the hospital. And some of those people get the disseminated disease, as Sharon is very much aware of it. Once the infection happens, you develop immunity, and the immunity lasts forever. Lots of times when I see patients in my office, my clinic, they say, so that I don't catch it. No, you don't catch the second time. But if you have it, it stays with you. So you can reactivate your disease if your immune system goes down. The second time is not a new infection, but it's reactivation of your old infection. So that's our nice desert here. And these are the mold, the mycelia that lives in the soil. And as they mature, these little parts break off. And then when they break off, they come in the air, they are airborne, they are very, very small particles, and you can breathe them in. And once they get into your lung in the right place, then they start growing. And one little one becomes a larger, then each one of them becomes about 300 or endospores in the big spherule, all microscopic, you can see that. And then once this matures, it ruptures, and each little endospores go through the same cycle. Okay, so when this happens, your lung is inflamed, you feel like you're having pneumonia, you're coughing. This induces your immune response, so you will have fever and chills and hacking cough and headaches and just the whole picture of pneumonia.
Stand it up or something.
And then hopefully your immune system is so good that you can control this and nothing happens. You just don't even remember you had that little flu-like symptom many months ago. Now, I like to think that we are the center of the world. Of course we are for valley fever, right? So about 2/3 of the cases of valley fever are in this, we call it valley fever corridor. And that is Phoenix and Tucson. Okay. Now, the common mild self-limited disease is with cough, chest pain, fever, weight loss. About a month or so, 2 to 4 weeks of incubation time is when the patients start developing these symptoms. And Fatigue is something that comes very early and sometimes lasts forever. I will come back to this in a little bit. And then bone and joint pain, and that's the reason another name for the disease is desert rheumatism. Develop this weird rash. I have some pictures of it. So a lot of times the dermatologists are the one who see these patients first. And then they send the patient to us because it's really valley fever that patient is dealing with. Course of illness, several weeks to several months. We know that about, in our study that we did in Campus Health, 1 of 4 college students who had this, they almost lost 4 months of their study. And for people who have this, 50% of these workers who have this, they lose about 2 weeks of work. So not only the clinical side of it, people suffer, also financially and work-wise, everything gets compromised. So community-acquired pneumonia, CAP, right? So about 25% to 30%, 1 out of 3 cases that happen in the picture of community-acquired pneumonia, they are valley fever. So remember, 1 out of those 3 people who come in hacking cough to their primary care offices could have this. Okay.
Can I ask?
Sure.
The CAP, how is that different from normal pneumonia? I've never heard of it.
Community-acquired pneumonia is pneumonia,
Okay.
okay? But it's bacterial pneumonia.
Okay.
We have atypical bacteria like plasma, stuff like that causes CAP. The presentation is identical. You have inflammation in your lung, you cough, you have fever, and goes away. The treatment for that, if you need treatment, is antibiotics, antibacterial. Because the presentation is so similar, how many times people go to their office, their primary care offices, and they get an antibiotic? That's perfectly good. But if it doesn't work, then you have to think about maybe there are other causes for this, you know. Unfortunately, in a study that was done by CDC, they saw the median number of times that people received antibiotic was 3 courses, and each course was about 10 days. So people got about a month's worth of antibiotics with minimal response, and of course, a lot of side effects. So we want to decrease that. We want to actually diagnose this early on to prevent all of that. So 1 out of 3, right? But lesser than 15% of these people get tested for valley fever. And now that is before the COVID time. I would say it's now lesser than 5% because everybody has COVID. People come to me, they had 10 COVID tests that were all negative. Still they're coughing, still they're getting tested for COVID. It's gotta be there, you know. Anyway. So we know that about 1,000 new medical licenses are issued in the state of Arizona per year. And if you look at the number of people who were graduated here and thereby probably know about the disease and heard from people like me, is about 12%. 40% of them never studied here and probably very minimally or familiar with the presentation. So 80% of these people who came to our area, they didn't know that valley fever is just like other reportable diseases for the state of Arizona Health Department. They didn't know that. And also they didn't know that we don't have a vaccine. Question mark here. We actually have a vaccine now. It's in the process for animals, for dogs, canine vaccine. So hopefully the next step after that would be for human. Long way to go there. Now, 40% of those clinicians that were surveyed, they said they really don't feel comfortable with this disease. They don't know about it. They haven't seen patients. So go to valley fever clinic. Guess how much time they need to wait to get to us? It's only me and Dr. Galgiani, so several months. So my schedule is triple booked and double booked, and I'm only one person, you know. So we want the disease to go to the primary care offices, thereby you guys get diagnosed faster and earlier. And I do this talk to a lot of people who are out there. So hopefully it sticks and they'll remember and they take care of these patients without sending them home. So this is a study we did, just show you how much work we have to do. This is in Banner from 2017 to 2019. You see 247 out of 1,800, which is 13% of these people were only people who were diagnosed in primary care offices. That's the yellow area. You see here inpatient, that means in the hospital. You see the Banner here or Banner Latino. Most of these people, 76%, had to be that sick to get admitted for somebody to think about it, to diagnose it. Now, our goal is to flip this, because once they get to this point, a lot of aggravation, a lot of anxiety, a lot of procedures that technically didn't have to happen. And this is a study we did, Banner Phoenix, and then the next one is my study here in Arizona, in Tucson, that you see about, we have about 43% of these diagnoses were at least a month delayed. These are 4 different presentations of the disease. You see here disseminated, that's the one that's valley fever related meningitis. Even in that case, people were delayed to be diagnosed for at least 1 month. Just gonna pause for a second, see what important it is, how important it is to see these people early and diagnose them early. So what happens when we have all these delays in diagnosis? Weeks of antibiotic, as I just mentioned. Lots of anxiety because patients are getting antibiotics. They're not getting better. They're still having cough. Sometimes they bring up blood. Oh my God, what do I have? So lots of this anxiety is going on. And then what happens? CT scan. They don't respond. Okay. PET scan. No. We got to do biopsy because they're not there. So imagine how many procedures could have been prevented and patients could have been saved before all this happened. So hypothesis is that early diagnosis improves the outcome, decreases the anxiety, decreases the cost. All of these are important matters. So this is another study we did a little bit later than previous one. Again, same time frame. And what we looked at was the community-acquired pneumonias in Banner Medical Group and Banner University Medical Group. These are both inpatient and outpatient clinics or studies. Total of these number of cases in these 3 years was about 2,200. Okay?
It's talking.
Out of these,
Coming through.
see patients who had estimate of maybe this patient has palsy, valley fever, was 57. So out of all these numbers, 2,200, about 1/40 of these cases were somebody thought about palsy. Now guess here, how many of these people actually were tested? All of those, because somebody thought about it, right? And then how many of them tested positive? 43. Okay, so you imagine if we time this 40, then it would be about 1,600 of these people should have been tested and might have been positive. So we actually showed this to our, higher ups in our community to show them how important it is to make people actually think about this in our community, in our providers group. So the second thing I wanted to talk to you about today is how to improve now this early diagnosis, right? We talk about it's important to do it. Now, how do we improve this? So the tutorial here, the booklet you picked is something we provide to lots of providers here in the community, hospitals, physicians, nurse practitioners, to have just in their pocket, on top of everything else in their pocket, to just look at it to see, oh, what did she say? How this present? So you have all of the information that is mainly written for the providers. The flyer you have, however, is a very brief description of the disease, where we are, our website. So hold on to that. And if you have any question, we have our phone number and email address for you to call us and inform us about your issues. So why we call this COXI is exactly this, primary care of COXI. We say, consider the diagnosis, order the right test, check for the risk factors, check for the complication, and then initiate the right management for this patient. All right, so in that booklet, you have these little diagrams. I'm not going to go through that, but to consider the diagnosis, we know that it is very common, right? And when would that be? Usually we know that between the monsoon season, that's the peak. So before the monsoon, when the soil is very dry, and before the rain in the winter time. So is the soil dry now? Sure, right? So then these little arthrochlamydia, the spores get airborne. And you could walk outside and catch it. Somebody was asking me, actually Sharon said, well, I want to advocate for wearing masks. Really, I mean, when you do extensive work in the yard and dig a lot of dirt, maybe it's a good idea, but you can't live with masks day in and day out, inside and outside. The type of mask you have to have is N95. So I don't know about you, but I can't stand them. So always when somebody has community-acquired pneumonia, did they do something wrong? Oh.
One person out there in Zoom that is still unmuted. Virgo is the name. Would you please mute? Thank you. Sorry.
No problem. So
Did you say
always
Burton?
in community-acquired
It did say
pneumonia, if you
Burton?
have the symptom or somebody has it, just say, oh, you know what? I heard this talk. They were talking about valley fever. When you go see your doctor next time, ask them to test you for that. That's all. And rheumatism, this achiness, everywhere is hurting. All joints are swollen. All joints are hurting, and it moves from one spot to another. Or weird rash. I'll show you the picture so you know. The second thing is for us, we say order the right test. And that's a blood test we do. Just to let you know, I don't know how many people know about this, but SonoraQuest Lab does it without physician order. Okay? You go to the SonoraQuest person and you say, can I have a test for valley fever? They order that. If it comes negative, it's about $30-some. Even if you don't have insurance, you can just pay for it. If it is positive, they report that result to your primary care physician. If it is negative, they call you, say it was negative. Done. We'll get to the result, how reliable it is, but at least you can do it yourself. Once you have it positive, then somebody will do something about it, So a positive is very specific. Once you got it, you have it, right? Now, how about the negative test? Does it rule out the disease? It does not. It's so-so test. At the best, the test that we have, yes, SonoraQuest, is about 46% sensitive. 1 out of 2 patients get missed. Also, it depends on when in the disease course you get a test. If it is too early, it doesn't catch it. If it's too late, it's already too late, it's not there. So we don't rely on tests solely, but if you have a positive test, then you don't have to go through all those antibiotic courses, The next step we ask people to do is check for the risk factor. And for the lung infection risk factor, these are the ones. So if somebody has diabetes, that's a risk factor. Like it is for a lot of other diseases, diabetes is a risk factor. Any heart or lung disease could be potentially a risk factor. Surprisingly, people have asked me asthma. Asthma, we have not found correlation between worsening valley fever and asthma. what COPD is and other lung diseases are. Next thing is for the disseminate, for the severe form, the major risk factors are when the cell-mediated immunity is down. HIV is a great example of that. And then pregnancy. I have a couple of patients who were pregnant during their valley fever, and we followed them very closely. Thank God everybody was fine, baby and mom. And then smaller effects, we know males more than female are at risk of severe disease. Actually, I did a study, I will have it towards the end of the talk, that confirmed that, although it was reported many times in the literature. And then racial background, African Americans and Filipinos are at higher risk of developing disseminated disease. And also adults more than children. Children get it, but then get over it very easy. I guess they have better immune system anyway. So then check for the complications. And this is really important. When patients come to us, we're gonna ask them for headaches, weird headaches, something that comes and doesn't go, and gradually get worse. It's not a throbbing headache, but it's there, you know it's there. Also, back pain, if the bone, the vertebral column is involved, and then the joint pain. And that's not like achiness everywhere. It's like one big, hot, tender joint. That's what we are worried about. And then skin lesions under the skin, like a little pus pocket, or there could be fluid in the joints. Those are all that we always look for and examine the patient for. Now, this is a little cavity. It's not that little, actually, sorry. This is your CAT scan of the chest. On the left side, you have good, normal-looking lung. On the right side, that's the cavity. And that has been there for a long time because of the characteristics of it. Now, this patient, though, has more complex one. It's a cavity with lots of brothers and sisters. I actually had a patient yesterday in the hospital that the whole right, left lung was one big cavity with a lot of little loculated area. And the guy was not admitted because of the breathing issue, had other issues. So you may not even know you have this big cavity. Diabetes is a risk factor for developing these large cavities. All right, so now this is somebody with a skin. Sorry to gross you out. I'm used to it. So these are skin involvement. This is type of disseminated disease. If you take a sample of this and culture it, you grow the fungus. This is different than the rash I was talking about. The rash is just kind of everywhere, it's itchy. In that case, that's immune response, and you cannot find the fungus in there. It's just part of your immune response. This is a joint, I think it was on the knee, if I'm not mistaken. And you see that there's like these little lesions that don't go away. They slowly grow, they drain and stuff. If you see something that doesn't heal, see your doctor, please. And then this is another one. And this was somebody, paraspinal involvement. So the upper thoracic spine was involved. And then the fungus found its way under the skin. This is a pus bucket that drained. This is disseminated disease, obviously. This is somebody that the joint was involved, the wrist joint. And a little young guy with joint involvement. So this complication, when we see something, we want to make sure that if these are in one spot, is it focal or not? We want to make sure that, we ask the patients all these questions, when this all started. So we like to be very thorough on this end. And then if there's something new, we want to make sure we send them to the right people. We get a biopsy, we do all the work that we need to do. Now, we do a chest x-ray usually. If you come to my office and you haven't had a chest x-ray, I do a chest x-ray. The reason for that is to see that cavity I just showed you, or a nodule, the inflammation in the lung become like a little nodule. That helps us because if you continue having issues and we repeat that, then we know where we are now. Is it better? Is it worse? Is it same? Is it something new in there or not? Then, important, if there is a residual nodule in there and you know, like Les, you travel back to Minnesota and now you have a cough and go back to your doctor and they do a chest x-ray, oh gosh, you have a nodule, you have cancer, let's biopsy this. If you have this, they compare and they say, oh, you live in Arizona, oh, probably it's valley fever, let's watch it. And the most patients usually to just get a chest x-ray. You really don't need a fancy PET scan, you know. If we are comfortable with the diagnosis, we can be comfortable with the way of following it. We don't need to send you off for biopsies and stuff all the time. Okay, now this is a chest x-ray of somebody in October 26th. When you come back from Minnesota, you're happy in your yard and you start coughing. And we see that little area that looks like maybe a pneumonia is developing. And then by November, that's a clear lobar pneumonia here. That's when you're coughing and fever and chills and stuff. And then gradually getting smaller. You see that by December, this was clear, almost. Okay, now the chest, this is the chest x-ray. You see that nodule? That's what we call nodule. Okay, you will hear that a lot. Somebody said I had a nodule, right? That's what they are calling it. And if you get a CAT scan of this chest, that's the nodule right there. Now, if somebody has history of smoking many years, no question that person get a biopsy. That's recommended. Pulmonologists recommend that. No question about it. But if it is very small, sometimes they follow that. And if they biopsy this little guy here and send it to the lab, then we get involved because they grow the valley fever fungus. All right, so now, how do we follow these patients? We get the blood test, right? And the blood test, one of the tests is titer. It shows, to some extent, we can say it shows the activity of the disease. So if the titer, that is usually should be lesser than 1/2, is like now at the peak of the disease is 1/32, it's high. I follow this every couple of months. And if it comes down, that means everything is going, you're doing better, then you're good. Nothing to be done. But if this titer starts going up, then I have to start looking around to make sure I'm not missing anything. If you see somebody with this, it may not go away in a week. It may take several months. And I always tell patients to be patient because this is not your typical pneumonia that comes and goes in a week. It takes a long time. Now again, if the titer goes up, then we have to start looking and make sure we don't miss any dissemination. And then at the end, I always tell my patient, the titer is only a number. I look at the titer, I look at the patient before I decide if the patient needs further workup or we just follow them. Now, I did a study, this was a new test. I'm hoping you remember I told you our test is just so, right? So there was this new test in the market and it is excellent test for Cryptococcus, another fungus in other setting. And the hope was that this is as good as for Cryptococcus, in our case, in our valley fever. So we did a study, we enrolled about 400 patients in our center and tested this test against our basic, SonoRequest blood test. Unfortunately, the sensitivity was not as good, but the specificity, it was okay. So the company is working on this. It's not yet in the market. It was supposed to be point of care that you draw like a little small amount of blood, you put the test strip, it's like urinalysis. You put the test strip in the serum, you wait 30 minutes, and voila, you have the result. It works that way, but it's not as sensitive as we wanted it to be. Anyway, so this is one thing that patients suffer from for a long time. Not everybody, of course, but a lot of people. So, over several weeks, when patients develop this disease, they lose weight because they lose their appetite, then slowly that comes back. They gain their weight, their fever goes away, their respiratory symptom goes away, all the criteria for the disease get better, right? But the only thing is that they still have extreme fatigue. And they come to us very frustrated. Somebody who was running several miles a day, now all of a sudden they can't do anything. So what do we do about it? How do this should be managed? Big question, good question. So there was a study done in Phoenix together, our group with a physical therapist, and they saw that the oxygen consumption in the muscles go down. Don't know how, we don't know how this fungus makes that, but maybe that's the reason. However, what we tell patients is decondition. You're deconditioned because of the whole process takes a while and you kind of don't feel like it. As you get deconditioned, you have to slowly recondition your body. And it's just like if you're a marathon runner, you start with a mile and 2, and then you add on that. You have to do the same thing here. If patients don't know this, if you don't explain to them about it, this fatigue makes them really anxious because they can't do anything. So we sit down, we talk to them about it. And one thing I always ask patients is to have reasonable expectation of their body. This is a major disease. You have to give it time to come back. And it will. The other thing is sometimes patients, I ask them to, let's see if I have it here. I ask them to keep a diary of what they can do weekly. And then they see that on the paper, they actually are improving, and that's reassuring for them. So now, excluding other things, if we have this fatigue and patient is not feeling better, make sure we review everything to make sure we're not missing a point that potentially is there. And then I talked about this deconditioning. Keep a journal, keep a diary. That would help, believe it or not, significant. And then say, okay, should we treat these people or not? See, I haven't even talked about what is the medication here. Because that is the last thing we think about. We try not to add stuff if we don't have to. So there was a study done, actually our guidelines that was written by our director, Dr. Galgiani. It should be emphasized that no trial to assess is either the antifungal treatment shorten the illness or prevent the later complication in people who do not have complication. We definitely have to treat people who have complication. That's no question. So there was a study done by Dr. Amcal in 2009. 50 people received treatment antifungal and 50 people did not. These are people who have otherwise no complication. Simple, good old pneumonia. And in these groups, 50 who got treated, they followed them for 3 years, and all of them were fine. 51 that were treated also for about 3 years. 38 of them came off of the treatment and had no complication after coming off. Some of them, but they wanted to, the patients. They were afraid of taking themselves off of medication. And 8 of these people who were on treatment, they had relapses. And if you look here, the relapse happened over 2 years after discontinuation. Some of them developed disseminated disease. So we don't take treatment very lightly. We want to make sure that the right person is chosen for getting the treatment. We have a lot of support resources. Part of it is here, our website. I just have this here for you so you know there's somebody out there to help you if you need anything. Now, there are metrics in Banner that we follow to see what all these lectures that we give to providers, how much does that help? And those metrics are the number of serologies that are ordered, how many tests become positive, how many of these diagnoses are entered in patients' charts, how many antibiotics have been used, and the new cases that have been diagnosed and then sent to us or pulmonologists, how many of them are there. This is kind of something we look at in our studies to make sure that what we are giving to these providers actually is helping. Now, this is during the time that I was doing that study for that new test, and you see that in Banner versus non-Banner, during that study, we had much more testing done because we were there in the emergency room constantly asking, can you test this patient? Can you test this patient meets the criteria? So clearly, it was a big difference when we were right there with them, with the emergency room physician. The last thing I wanted to talk about is management of patients who are on these biologics. Maybe some of you guys are. So what happens? They decrease your immune system. What about valley fever? Do we put you at risk? Or if you are on this medication, is the medication bad for you from the valley fever standpoint? So we know that a lot of these biologics have been used nowadays for a lot of diseases, rheumatoid arthritis, ankylosing spondylitis, psoriasis, Crohn's disease, all of these, and these are excellent medication, no question. However, it does increase the risk of infections such as endemic mycosis. One of them is valley fever. So some patients, not everybody, remember, some patients who are on these medications handle the valley fever poorly. So let's see here. So the risk of the disseminated disease rises about 150-fold when people are on these immunocompromising conditions and medication, including chemotherapy for that matter. So clinical question is it safe or is it not safe in the endemic area to be on these medications? Right? So we did a study here, and I'm going to add this part to it. This is in mice. Two groups of mice that are sensitive to valley fever. We gave them the valley fever fungus spores, and one group received the anti-TNF. This is one of the bigger classes of the biologics that people are on. We gave that up to day 14 of the infection, and in another group, the blue group, we gave them all the way through day 70. Okay, and you see that even short course of this die much faster than this control one that never really didn't die. So we clearly can see that TNF, which is one major group of this medication, is important to protect people. And when we block it, which is rightly so for diseases like rheumatoid arthritis, has to be done to decrease the inflammation, that increases your risk of infection. So now, what I just finished and published, just came out, is in open form infectious disease. We did a 2-year study, and this is retrospective. We looked at patients' chart in our system. The medical records were viewed based upon the coding that they put in the chart for valley fever and autoimmune disease, 10,000 charts and 1,300 for the valley fever. And this is the diagram we followed, actually. We had about 1,000 charts that had overlap diagnosis. And some of them were excluded for reasons. I'm not going to go through details of it, but people who did have confirmed valley fever, about 587, 138 of them had autoimmune disease with valley fever, and 449 did not have autoimmune disease, but had valley fever. Now, overall, I don't know what you think, but maybe people thought when you have autoimmune disease, you are at higher risk for valley fever. How many people say yes? Because it's not. Autoimmune disease, we proved, and I'm going to have that here. So in this study, male sex was associated with more valley fever, already published. So we were happy that, okay, our population follows the rules. Then African ancestry in our study had 3 times more likely than those European ancestry to develop severe disease, disseminated disease, also published. So we are kind of corresponding with other publications that have been done before. And then when we compared valley fever and autoimmune disease versus people who didn't have autoimmune disease, you see that there's no significant difference in the valley fever presentation. That's good news, right? Now, when we go through the valley fever, disseminated disease, which is the severe form, you see that when people are on these biologics, they have higher risk of developing severe disease. And that's actually one of the first studies that have been done to show that with numbers and clear evidence. So this is the same table that actually is in the paper. If you look at the total number of patients with pulmonary, means lung involvement versus disseminated severe disease, 9 of 19 of disseminated disease were on BRM versus only 17 of 58 of the total, actually 75 people were on biologics. So clearly, when you have biologic, you are higher risk to develop disseminated disease. The hypothesis is that if you have adaptive immunity, and that means you have seen the disease in the past, now you have the disease, you have the immunity, and now you see that you are on biologics. When you have adaptive immunity, when patients have prior epoxy, this could protect them to some extent when they are on biologics. So bottom line is, if you come to me and say, I have lived in Green Valley for 20 years, and now my doctor wants to put me on Humira, and they did a blood test because that's somewhat required to do for valley fever. And the valley fever test is positive. And now they send me to you. What do I do? If you have been here, I assume you do have this adaptive immunity. I think you have lesser chance of developing dissemination than somebody who just landed. That's one thing I'm trying to actually do here. Prospective study, we are applying for grants through NIH to actually do this study to prove this. This is a hypothesis. I could be wrong, but evidence lead me to believe that adaptive immunity actually is important here. So let's see if I have anything else. So we want to actually, using this study, use some cell markers that could be potentially a better way of diagnosing this disease and diagnosing the previous exposure to the disease than what the tests we have right now in hand. So in summary, overall, we want to actually changing the way that people, providers in the community think about this disease. And we want to make sure that we expand the knowledge to everybody so patients don't wait forever to get to us to tell them something that could have been done many, many months before that and hopefully prevent a lot of complications on their side. And thank you for your time, and I appreciate the opportunity to be here. And I'm going to take any question. Yes, sir.
Well, you talked about the highest rate of incidents occurring between monsoons and the winter rains.
Mm-hmm.
How do we keep from getting this disease during that period of time or any time? What do we do?
Well, if you have a project in the garden, wait if you can. Or if you have to dig the ground, or, you know, a good example of it is the solar farms in California. they had a lot of workers who worked in those solar farms catching the valley fever. So wearing the proper masking and proper protection. But really, at the end of the day, I have a slide, I didn't put it here. Don't breathe.
For the rest of the year, how exposed or how possible is it that I'm going to get valley fever hiking?
All of us are exposed. How is your immune response responding to that? We don't know. If you have other comorbidities, your risk, what I mentioned here, your risk is increasing. But who am I to say? You may control it and you may never know, because you may never have the symptoms to go and get it checked, you know? So it's really, individual immune response is very important. And that's what we were talking about. Yes, ma'am.
And you are not going to prescribe prescriptions or medication. What do you do for them?
Very good question. I spend a lot of time with patients educating them about the disease. This is not a disease that here is the pill, we're going to take care of it. Your blood pressure goes down once you take this blood pressure medication. This is a disease that patients need to know about it, how it works in the body. And in some cases, I have to treat if they are really severe, but if they are not, I just educate them about the process, the pathophysiology of the disease, the reconditioning is important. They have to be patient with the disease. And a lot of times, actually, that helps. Yes. That's a great question. It's not contagious. So we are ahead of COVID there. It's soil. Remember, the mycelia goes, is in the soil, and then the arthrochonidia comes up. So it's airborne from soil. Only a couple of cases of, actually, no, never mind. No human cases. Maybe transplacental have been reported, but really not. Yes, I'm sorry, somebody had a question.
My question was answered whether it was contagious.
Yeah. Yes.
You know, I was training here in the 60s, and the rumor was valley fever was coming from the number.
That's moist, right? Moisture prevents the endospore or arthrochonidia production. So when you have a lot of rain, actually the mycelia grows in the soil, but it doesn't produce the arthrochonidia yet. So I don't know. Yes.
The big thing we have, our responsibility down here is we have people coming from Denver, Colorado,
Yeah.
places like that, is to tell them about valley fever. So if they
Exactly.
get home and they have symptoms, they get.
So I get phone calls from Washington State Hospital, Dr. Jill Smith or Joe Smith. I get calls from, I have a patient who's in Germany, the physician emails me. We get a lot of calls from Minnesota, from Washington, D.C., because people come here, you're right. And that's the reason we are here talking about this, because then you can spread the word, please.
Yes.
I was in Mexico when the Hanta virus.
Uh-huh.
Is that with soil, also soil-based virus? Is that any type of?
Actually, New Mexico has cases of valley fever. Yes. So part of New Mexico. The patient I had yesterday actually lived in Albuquerque for many years, so he probably got it there. Yes.
I've got sort of two questions, but one is about the biologics. I guess I have to use him as the example. He does have Crohn's disease. He's
No HIPAA, right? Yeah.
He has resisted going to the biologics, a lot of it because of the side effects. But is this another sort of rationale if you're spending half your year here is it another rationale to stay away from the biologics because it would increase your risk? Or would you discount that?
It's a great question. We always go back and forth with rheumatologists or gastroenterologists with that. Patients suffer from their disease and they do need this medication. And no question, these medications are great for what they do for that specific disease. Do they increase the risk of infections, all infections? Absolutely. So, as long as people know about it and they know that they put themselves at risk, sometimes when people have to go on these medications and they have valley fever, what we tell them is, if you and your physician decide to go on this, we start you on treatment, antifungal, for valley fever. And as long as they stay on this regimen, they stay on antifungal agent. That way, at least, not that we prevent it from happening, but at least we decrease the potential risk of dissemination and severity of the disease.
And is there any value in knowing, I'm thinking of a.
How do we turn it off? Down to 20. Pardon?
Based on kind of the valley fever symptoms, is there value in knowing, like 2 years later, that you're positive?
22,
for it?
we did have 30. Really long-term breast tube.
Not sure if I understand your question.
So, let's say you're never tested for it,
Uh-huh.
but you're just in a period of diminished health and all this.
Oh, I got you now.
Yeah.
So yes, that's the reason.
In knowing later on.
Absolutely. So you got tested negative, but you were saying you had severe pneumonia there.
Right.
And your immune system was down. And you may never catch that positive test. And that's where it comes to, we are looking to have a better test to test your past exposure, past immunity. Absolutely, you're right. Yes, ma'am.
You think all children that grew up here or grow up here have had it, and you see any children that have the severe repercussions from it?
Exposed to it. Did they all catch it or not? Who knows? Yes, I do. I don't see children under 18 or sometimes 16, but yes, children do, some of them do develop severe disease. Mainly those people who, or children who do have some underlying immune deficiencies. Potentially, yes, they are at risk. Yes, ma'am.
Is any of the information that you've given today pertinent to animals?
Absolutely. So the vaccine that we are developing, and it's almost there. Hopefully, we are hoping for failed trial of the vaccine next year, is for dogs. Okay, so very promising vaccine. Actually, our COXI conference, annual conference, is in April in Bakersfield, and we'll have a whole session about the vaccine. Our vaccine presentation will be there. This is done through a commercial company, so we have to get permission to talk about it, but it's already published. If you look up canine vaccine for valley fever, it will come up, and you see about how important it is to actually keep at it, because that's the first step towards the human vaccine.
But felines can get it also, right?
Yes, but how it works is in the FDA, you have to choose a host animal. And since dogs are getting it very severe, the host animal for us was dogs. So beyond that, can they use that vaccine for other animals? Most likely, yes. But we are not supposed to say that because that's what is not tested. Once it is out, the veterinarians will use it for, say, cats. What's the harm,
Right.
We are hoping that it comes in the market with reasonable price, so it's not like horrible for the owners to deal with, One other thing I wanted to talk to you about is, actually, I'm sorry, I keep blocking you. Call your representatives. Time convincing them that this is a lot of people and their animals. And we are forgotten disease. We always say that. When Zika came, we went down the list. When COVID came, we went again below the lower level. And it's an important disease. It's a low, but a lot of people get exposed to it. And believe it or not, it's really hard to convince them that we are here and people are suffering. So I think when we have some patients that they come to our conferences and they present their history to the local officials, sometimes that works, sometimes. So give them a call, give your representative a call and say, hey, what have you done for valley fever research?
Okay, it's after 10 o'clock.